It's 4 p.m. Italian time, so it's a time for Food for Baines, Baines for Food. As always, we will welcome 30 seconds for allowing everybody to join the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and welcome everybody again to Food for Baines, Baines for Food, a not-for-profit humanitarian and educational initiative that always starts with the art and heart of Monica Glowinski, dedicated to all the health professionals who have shown such a good heart during this tough COVID time, to which this humanitarian also initiative is dedicated to, in particular in the support of the economic crisis that is following the lockdown policy as requested by the Lancet publication. Nothing would have been possible without a truly stellar faculty involved both in recorded video lessons and also in these live webinars, and also thanks to all the attendees to these live initiatives every Sunday. I take this chance to deeply thank Professor Bradbury, who shared with me last webinar, and we already replied to the 45 questions that were asked during the live, and you can find them in the website. So I encourage you to do the same also today. You have a question and answer box where you can ask in whatever language the questions to the huge keynote speakers we have today. Today that is dedicated to advanced chronic venous disease, a day in which we will provide once again international and national CME credits. We have truly two huge speakers today, Professor O'Donnell and Professor Marston. We will introduce them properly later on. I take this chance to deeply thank also Professor Raffetto and Professor Mosti, who took part in the previous recording of the extra educational material you can find in the website. I take the chance to thank them for serving as honorary chairs, as I deeply thank also Professor Zamboni, one of my mentors, for serving as well as honorary chair today. It's a special honor for us having Professor Romanelli in representation of the World Union of Wound Healing Societies for wrapping up the concepts that we will share today in this particular webinar, where we enjoy also top continental experts. We will introduce them properly one by one later on. So deeply thank to them, deeply thank to all also the individual donors and the magnificent 7 companies who supported by means of unrestricted grants this humanitarian and educational initiative. So thank you to Amnol, Balton, Bayer, Medi, Servier, Sigvaris, Tactile. Thank you to all of you. I hope to be with all of you as soon as possible in a moment in which talking about food not just for humanitarian purposes, but also for social gathering, that today we could have dedicated with a birthday cake to 2 Italian pillars of our national phlebology, Alessandro Pieri and Paolo Valle, who are celebrating their birthday. At this point, as always, I pass the mic to outstanding colleagues who I also call family. So Professor Bottini and then Professor Chi. The mic is to you.
Dear friends, once again, it's a wonderful opportunity to be together with friends and experts from all around the world. Remember, you can make questions in any language. A todos los de habla hispana, por favor hagan sus preguntas en español, que serán respondidas a la brevedad. Gracias. Y si você tem alguma dúvida, faça su pregunta em português. Obrigado.
Thank you for adding also Portuguese this week, Oscar. And then we will move on the way to California for a gold medal of commitment, because it's 7 a.m. for Professor Chi, and is opening. Willie?
Yep. Good morning to myself, I guess. Good afternoon, good evening to everyone who's on the podium in the world. Today we have 2 great speakers, and please enjoy. 各位先生们、各位女士们、各位同道朋友们，大家早。今天是我们第5次的往事视讯，请大家任何问题，请在回答箱里问你的问题，我们会按照顺序一一答复他们。Thank you，谢谢。
Thank you so much, really, also for the special Chinese message of writing the questions in the question and answer box in whatever language you want, even Chinese. As you know, at this time, we give the mic to somebody that is close to our Venus ward, and then in this case is representing the nursing ward, and in particular, the nursing excellence. We could not find a better figure for this. Ellie Lindsay is known by the vast majority of us. She's the founder of the Lindsay Leg Club, and her commitment to the cause led her to get even this special recognition from the Queen of England herself with the Order of the British Empire. So Ellie, the mic is on you for 1 minute now.
Thank you very much, Sergio. Chronic venous disease we know is a common disorder, yet little attention is focusing on the wide range and the impact the disease has on individuals. And what's concerned me was recently a parliamentary review of England identified that over 200,000 people annually, experience leg ulcers. And that really is unacceptable. And also disparity of pre-assessment and actual care delivery. That really has to change, because as practitioners, of course, we embrace modern technology, but we need to embrace vascular techniques and, most importantly, research evidence-based care delivery, because the public in this day and age expect the best of care, and quite rightly, they deserve the best of care that we can offer them. Hence my commitment to the Food for Veins project and the Veins for Food, which is just as important, but also the Legs Matter campaign in the UK, where we are desperately trying to raise venous awareness to the public, and obviously to clinicians as well. And it's a privilege to be part of this fantastic project. Thank you.
Thank you so much, Ellie. I hope you could hear all the people clapping you. We are like already more than 500 live. So you know that usually we couple the big keynote speakers with a huge artistic figure, and now we finally get into the scientific part of the webinar. Knowing Professor O'Donnell, I guess that we can make an exception, because even more than artistic figure, he maybe enjoy Phil Mickelson as a metaphor. He is a world champ of golf, as is one of our champ in the venous and vascular ward. He needs no introduction, so let me just try to sum up this with 4 points. He has a Harvard background. He also served as Mass General, and he has been a leading figure of the prestigious Tufts Medical Center. But more than this, he's also a true master for many of us and a real gentleman. So now I will pass the mic and the screen sharing to you, Tom, and we will look forward for enjoying the role of the lymphatics in advanced chronic venous insufficiency lecture. Tom, the mic is on you. You can share. Can you hear us? That's
yes. Good. There we go. Thank you very much, Sergio. Am I coming through?
Yes, you're perfect.
Good.
You can go.
Okay. Thank you for inviting me to this wonderful effort that we actually deliver some academic performance, but also through the charity help other individuals. Today, I'm going to talk about the role of the lymphatics in advanced chronic venous insufficiency. And it's appropriate that I was introduced by Ellie Lindsay, because as you will see, my interest, which has been over the last 45 years, was stimulated by a year spent in London at St. Thomas's Hospital. It's not advancing.
Khaled?
Sorry.
Khaled, can you overrule the slides?
Why is it not advancing?
Khaled, can you check if you can eventually overrule his presentation? Or maybe there is some delay?
Doctor, would you like me to share it for you?
Yeah.
Okay, so we will now share on the screen of Khaled directly.
Okay. Next slide.
I will stop the share and I will reshare again. Okay, Doctor?
Okay.
Technology is beautiful when it's working, plus we have always a plan B and also a plan C. So if the sharing will not work, we even have a video. And if the video recorded doesn't work, we simply go home and we enjoy our Sunday. Because if all the three things are not working, then it's too much. But we have already the PowerPoint in Khaled's computer. So now Khaled will share from his computer, Professor O'Donnell can advance from there. And if
I
not,
don't have the point with me here.
so you can retry to the Professor O'Donnell slides. Can you try again to share, because it was working just when we tried before getting started?
Just doesn't advance.
But it advanced before when we tried that, Tom,
Yes.
before getting started. So maybe you have the button on the top left, on the down on the left, on the right, or maybe you want to use the arrow of the keyboard.
All right, we're going to try it again. Okay. Thank you very much, Sergio. As I said earlier, when we went through a drill, it was like doing a first carotid. These are my disclosures relevant to this presentation. Certainly, the term phlebolymphedema is a relatively new one, introduced as shown on this screen in 1998, formally into the literature. And it's a swelling of mixed etiology where the lymphatic system is unable to adequately drain the interstitial fluid. Just trying to get that. There we go. It's composed principally of clinical classes C4A through C6 and combined with lymphatic dysfunction. And this is its distinctive format. As I said earlier, my interest in venous ulcers and lymphatics was prompted by a year with two of the world's expert, now departed, Professor John B. Kinmouth and Professor Norman Browse, both at St. Thomas's Hospital, London, who stimulated this interest. When you look at patients with lymphedema, the common concept is that the most common cause worldwide is filariasis, which is true, but post-cancer lymphedema. I think we're growing to appreciate in the United States that phlebolymphedema is really the leading cause here of patients with lymphedema. And this study from Steve Dean shows the predominance 46% in nearly 450 patients that he treated over a 4-year period. You're well familiar with the anatomy and function of the lymphatic system, where the lymphangion, if you will, is the heart of that system, the so-called peripheral pump, which is lined by smooth muscle and propels fluid through valvular structures back through the thoracic duct into the venous system. Now, the key functions of the lymphatic system is one, interstitial fluid homeostasis, with which we're well familiar. But what I'm going to focus a little bit on today is immune surveillance and its role in combating infection. Lipid absorption in the gut is another important factor, but will not be addressed now. This is an important cartoon because it contrasts the classic model, our understanding of fluid transport, started by Starling, with the newer concept. The Starling model is that the arterial side drives out pressure, drives out fluid, and on the venous side, the fluid is reabsorbed back into the capillary and accounts for 90%, if you will, of the fluid reabsorption, and only 10% comes through the lymphatic capillary. Levick and Michel did a groundbreaking series of experiments where they showed that this is not so. What happened is that there's fluid discharge along the entire capillary bed and no venous reabsorption due to the glycocalyx, so that 100% of fluid transport has to be through the lymphatic system. And this emphasizes the key role of the lymphatics in fluid transport. Edema formation in patients with advanced chronic venous insufficiency, as you can well appreciate, is due to a fluid overload in the interstitial space as a result of increased venous pressure. And this requires increased lymphatic transport. A failure to adequately cope with this increased fluid filtration into the tissue produces edema. And this interstitial fluid can be further increased by extravasation related to a decrease of intravascular oncotic pressure and increased permeability of the capillary membrane. Over time, there is damage to the lymphatics, so the transport is further impaired. Several pioneering studies in abnormal lymphatic function in chronic venous insufficiency have come from, in the past, Mortimer, who showed with quantitative lymphoscintigraphy that C6 patients had markedly reduced lymphatic function in comparison to 22 controls. And then the pioneering work of Bollinger, who performed fluorescent microlymphography, showed obliteration of part of the superficial capillary network of the skin, producing lymphatic microangiopathy, not unlike what we see in the venous side. In collaboration with colleagues at the University of Texas Houston, Eva Sevick and John Rasmussen, we have used a different technique, near infrared fluorescence imaging, NIRF, to image the lymphatics. The technique employs some of the military night goggle vision technology. This is a study where indocyanine green has been injected intradermal, and then the NIRF is applied. On your left, you see normal lymphatics in the foot. By contrast, on your right, you see abnormal lymphatics secondary to a patient with lymphedema. In addition to the morphologic changes, this slide shows the functional aspects of the study, where the amount of fluid transported and the contractions of the lymphangion can be measured. So it provides both morphologic and functional assessment. We use this technique to look at patients with venous stasis ulcers. What we found in the initial before treatment evaluation was bilateral dermal backflow. There was abnormal periulcer lymph pooling in these C6 patients. And most importantly, there was diminished contractile events in these C6 patients, which were too infrequent to be quantified compared to the normal 0.46 contractions per minute in normal subjects. And finally, fewer functional lymphatic vessels are observed, particularly in the patients with the longest duration of ulceration. And this just shows an example of massive dermal backflow up here and a dilated lymphatic. This shows again around the ulcer at the bottom, dermal backflow. In addition to the interstitial fluid homeostasis, as I mentioned earlier, the second role of the lymphatics is immune surveillance so that infection can be combated. Infections in venous leg ulcers have a prevalence rate which ranges from 13 to 25%. The recurrence rates are actually double that, remarkably high. And the risk factors listed here are obesity, damage to the cutaneous barrier, and the C6 patient is a perfect example, venous insufficiency, and lower extremity edema. The impaired lymphatic function increases susceptibility to infections. Infections, as we know, can be rapidly invasive and can cause septic shock and death. And it's not unusual in our practice in the past to encounter a patient with lymphedema in the ER who's hypotensive due to the infection. The major risk factors are skin breakdowns, where you disrupt the skin barrier, which elevates the risk of developing cellulitis and is obviously important, and the patients that we're discussing with wounds and ulcers. Most importantly, it prolongs the duration of the infection. On a macroscopic level, the protein-rich lymph fluid presents an ideal culture medium. When these patients are examined, they have a loss of adaptive immune response, and they have a deficiency in both humoral and cellular responses within the lymph node. But paradoxically, when skin samples are examined, they have an increased number of cells in the affected skin. The cellular level effects of secondary lymphedema are less well understood. However, there's a major increase in regulatory T cells, TREGs, which lead to an inhibited acquisition of T cell mediated immune response, most importantly, impaired bacterial phagocytosis, and both innate and adaptive immune responses are impaired. We recently examined our experience with infections in patients at Tufts. 78 patients all had as entry into the study 1 inpatient admission for infection for an 11.5% rate in this group. The only risk factor, probably due to the small numbers that could be identified, was a greater proportion of patients with congestive heart failure. But I would underline, as Ms. Lindsay discussed, the tremendous costs here in the United States with infection, real costs of about $30,000 versus the non-infected patients. And when we looked at what were the elements of costs, obviously it was due to inpatient costs and, most importantly, the necessary home care nursing. Well, we're very familiar with the treatment of venous hypertension, which is the hallmark of treating patients with venous ulcers surgically with ablation of the saphenous vein, and for outflow disease, the placement of a stent. What about treating the lymphatic component? Well, there are several treatment modalities divided into complete decongestive therapy with manual lymphatic drainage, compression bandaging, and skin care, as well as mechanical means such as pneumatic compression. This shows nerve with manual lymphatic drainage. You can see the flow of lymphatics up the limb. This happens to be an arm, but you can see the direct impact. We looked at patients with venous ulcers as shown on this slide, and the effect of advanced pneumatic compression. And what you see in the left is before, and the right after. There's recruitment of lymphatic vessels in these patients with use of the pneumatic compression device. Summarizing that finding was that we saw newly fluorescent lymphatics in 7 out of 12 subjects. There was emptying of the fluorescence from intravascular or extravascular spaces, and the major routes of lymph fluid clearance appeared to be through the interstitial space as well as the recruited functional lymphatics. Finally, to look at the impact on economics, we used big data, principally payer records from insurance companies to detail the impact on patients. This shows a study from Blue Cross Blue Shield where nearly 27,000 patients, the study population, were examined, and we compared venous leg ulcers to breast cancer for utilization of treatment of lymphatics. And this slide shows the results, the fact that breast cancer patients were more frequently treated specifically for lymphatic problems with therapy, 94% of the time, compared to venous patients 82% of the time, producing what we would call a treatment gap between these two causes of lymphedema. When we look specifically at the treatment modalities, comparing breast cancer to venous leg ulcers in these 27,000 patients, you can see a dramatic difference between the patients in red with venous leg ulcers and those in blue with breast cancer, in that conservative therapy and manual lymphatic drainage are used much less frequently. By contrast, when you come to simple pneumatic compression devices, they're used more frequently in patients with venous leg ulcers, probably due to the fact that the physician is trying to reduce venous hypertension. Can improvement in lymphatic function by these devices reduce the incidence of infections in these patients? One of the more recent studies is that of Maldonado at the New York VA, a multi-center trial. 74 patients followed for a year, and the data shows that the reduction in cellulitis from 24% pre-treatment for a year, over a year, to 9.5% afterwards, and both the number of episodes and the hospital admissions were decreased by this therapy. This shows another study where pre and post incidence of cellulitis was compared before and after treatment, and this is reduced by about 75% in these patients with principally phlebolymphedema. Finally, we looked at the cost in patients per year in this same large group of Blue Cross Blue Shield patients, comparing conservative therapy to pneumatic compression, and saw both a reduction in total costs from nearly $16,000 to $6,000, particularly in the inpatient costs. So in conclusion, phlebolymphedema affects a substantial portion of the population and certainly is the most common cause of lymphedema in the United States. However, the lymphatic component is underappreciated, and we should optimize treatment addressed to the lymphatic component to reduce costly complications such as infections, because this will have an important impact in quality of life and healthcare costs. Thank you for your attention. I bring you comfort from Hyannisport. This is located about 500 yards from where I'm presenting this talk. Thank you.
Thank you so much, Tom. I hope you could hear all the people clapping for your wonderful lecture that was deserving the Professional Golf Association, of course. So let me just move forward with our formal standard format, which is in this moment to start the World Scientific Round, for which we have top continental experts that are giving you the questions as a scientific reviewer. And it's my deep honor to start from Europe, introducing Professor Boiler from the University of Vienna, and she's also the president of the Austrian Society of Phlebology. So, Cornelia, the mic is on you for the question to Professor O'Donnell. And you have to unmute yourself. Unmute yourself. And thank you for being here with us on a Sunday, on a vacation day in Italy, as you know.
Okay. You can hear me now?
Yes.
Yes. Okay. Then, Sergio, I just want first to thank you for inviting me to this faculty. It's a great honor to be with you. And my question would be, I wanted to know what is the morphological substrate for the phenomenon of the dermal backflow? And is it reversible after the healing of the ulcer? Are there also results, study results to this question? In real life, as we know, we very frequently now are confronted not only with simple venous ulcers, but very often we have mixed ulcers, especially ones with microangiopathic components. There, I think the disturbance of lymph flow is more likely due to already inflammatory processes. Is it feasible to, or could you comment on the possible therapeutic consequences of compression in these patients, where compression might be also devastating to the microangiopathy, to the microvascular situation? Thank you.
Thanks to you. Tom?
Thank you for your question, Cornelia. First, obviously, as we all know the dermal backflow is at the ultimate endpoint of the lymphatic network, and due to reflux back from the lymphangiogland into the subdermal lymphatics. As far as what does compression, and I would here use pneumatic compression, what does it do to this area? We have not seen a reduction in the dermal backflow in patients either during treatment, which was studied using LymphoPress, or after post-treatment studies. So it doesn't change that. What it does do, however, is improve the lymphatic flow generally for the limb. I would state also that I don't think it has deleterious effects on either patients because of the mix, because the pressure is a relatively low one, at least the one that I use, 40 to 60 millimeters of mercury. Thank you.
Thank you so much, Tom and Cornelia, for the wonderful question. There are some mics to be shut down. Khaled, please. And now we'll fly all the way to Latin America. And please, Oscar, introduce our continental expert representative from there.
Thank you, Sergio. Let me introduce Dr. Marcelo Liberato, who yesterday gave an excellent talk for our Latin American Society, which meet every Saturday. He represents the Brazilian Society of Angiology and Vascular Surgery. Marcelo?
Thank you, Professor Bottini. Thank you, Sergio. Again, this is a great honor for me being here, a member of this faculty. And this is a fantastic meeting, web meeting. I would say that Professor O'Donnell, it's a great honor for myself as well to comment on your presentation. You make a part of the history of how important is the lymphatic situation of the patients regarding the advanced chronic venous insufficiency with your papers. And this is, I think today is a common knowledge that every single patient with advanced chronic venous insufficiency have some lymphatic impairment. I was wondering about, and we all know as well, all around the world, this is a nice meeting to talk about this. We have a huge gap of treatment for patients with venous leg ulcers. Many patients, millions of patients around the world without treatment. But going to the specific point of my question, in our experience, 12% of my patients who have a high volume center for treating venous leg ulcers in Brazil, and 12% of my patients have a mixed leg ulcer with arterial and venous impairment. I would like to understand, and I'd like to have some tips and tricks of your practice regarding the use of pneumatic compression in these patients, because we don't have a really spread use of pneumatic compression in our patients yet in general in my country. And I do believe on that, okay? I'd like to know what you think about the pneumatic compression in patients with mixed leg ulcers and some arterial impairment, and of course, inflammation. Thank you so much.
Thank you for your question. Dr. Bottini, I feel very warm that you're introducing everybody because I have a grandson by the name of Oscar. It's a great name. What I would say is that I've been using pneumatic compression for patients from lymphedema for over 35 years. Specific to mixed ulcers, you have to avoid high peak systolic compression pressures. And the device I use, not to stay generic, has a peak pressure that's less than 50 millimeters of mercury. So it's been studied and it does not have a deleterious effect on the arterial circulation. Indeed, we know some people are using compression pumps to improve arterial circulation by emptying the venous side. Be that as it may, from a practical point of view, what we do is obtain either a Doppler ankle pressure, posterior tibial or dorsalis pedis, that should be greater than 60 millimeters. If you have a diabetic patient, then you need a toe pressure. In addition, we use pulse volume recording amplitudes to screen out those patients in whom we would feel that the compression might have a deleterious effect. So it can be used in a lot of patients, but certainly it's limited by the downside of the systolic pressure.
Thank you so much, Tom. Now we fly all the way from Latin America to Asia. Willie, if you can introduce our continental top expert.
Yeah, next we have a good personal friend and a good friend to VWin, Professor Rahul Jindal from India, who is the past president of the Indian Society of Vascular Surgery.
Rahul?
Rahul?
Thank you. Thank you, Sergio, and thank you, Chi, and thank you, Professor Donald, for a fantastic lecture. I want to ask you a very practical question is, so what I understand from your lecture, that all venous ulcer pressure patients whom we are treating with 4-layer compression bandage, we should add a manual compression or a lymphatic pump, because it may be that they will heal faster instead of just using a 4-layer compression bandage.
Thank you very much for your question. As Ellie Lindsay said earlier, we base our practice on evidence-based. And unfortunately, at this point in time, there are no prospective randomized trials that show an impact on ulcer healing. And as you appreciate from the ESCAR and Everett trial, that requires a massive number of patients. Both of those series were 500 patients. And there were very restrictive entry criteria. But one would assume from the physiologic results, and also most importantly from our big data analysis, that that addition of a pneumatic compression device would aid these patients in combination with compression by bandages. So still waiting.
Thank you so much, Tom. We conclude the World Scientific Round flying all the way to North America. And it's my pleasure to introduce Thomas Serena, a huge expert on the field. He has even founded the Serena Clinics, dedicated indeed to wound clinics. So Tom, the question is for you, to Tom.
Fabulous lecture. Thank you so much. It was really worth attending on a Sunday morning. It was terrific. My question, as you know, we're huge fans of pneumatic devices, and when we can get them approved in the U.S., we are adding them on to our venous program. As you said, there's not been a big RCT, but we certainly have observed, as you said, improvement. My next question is that we've seen reading a lot of mostly case studies, nothing big, but about lymphatic venous anastomosis being done by some of our microvascular surgeons. And I wonder if you have an opinion on that, Tom.
Well, lymphatic venous anastomoses are appropriate in a selected group of patients, not being a plastic surgeon like yourself, but just from my own experience in reading the literature. I think that patients with phlebolymphedema would not be ideal candidates because of what happens to the lymphatics, number one, and the underlying lymphatic vessels that you're trying to anastomose to an already defective venous system. So maybe in post-cancer oncology treatment patients, or that would be a good venture, but I don't think it is applicable due to the damage to the lymphatics and most importantly, the venous problems in the phlebolymphedema patient.
Thank you so much, Tom. Now we open the mic. There is some mic to be shut off. Khaled, please. We open the mic to the audience, and as always, we welcome the one who is getting more likes. And the winner in this case is Mohammed Hassan Abdelati. So we fly all the way to an Arabic country. And he's asking to you, Tom, do you recommend compression therapy and manual lymphatic drainage during active ulcer or only after healing?
We recommend it during active ulcer because you want to promote the lymphatic drainage, avoid that area. It's much easier to do, however, with a pneumatic compression device because you can put ulcer bandage right over the ulcer itself and then put the pneumatic compression device in a stockinette to protect the leg. So in my opinion, the pneumatic compression device certainly has an advantage. But yes, why wait? You need to get started with the treatment.
Okay. And thank you so much, Tom. It has been wonderful, for real, an honor having you with us, and whatever comments of yours will be welcome in the second round. That now is the second 9 holes, we could say, for the golf metaphor, because now we move from Phil Mickelson to Rory McIlroy for the ones who are loving golf, because indeed Professor Marsden is another friend of ours. We met on the field, but of course we met him before on the medical field, where he is for sure another world champ. He has an Harvard background as well. He is the chief at the University of North Carolina. He's in the leadership, as we know, of the American Venus Forum. And as I said, he's a good golf player, but even more, he's an excellent friend. So Bill, now the mic is on you for sharing your slides also to talk about negative intermittent pressure. Do we really need them? Bill, you? Okay.
Hey, Sergio, and
yeah,
let me share this screen and make sure you can see everything, and we'll get started.
That is perfect. You're perfect.
Excellent. So it's a great pleasure to be here with everyone today. I'm spending the 4th of July in a remote corner of the North Carolina mountains. The population is so low density here, you can't help but socially isolate. So it's a real pleasure. The topic that Sergio and his colleagues have given me, I think, is quite intriguing. And these are uses of mechanical forces to help venous leg ulcers heal. And the question is, do we really need them? So let's move right forward. I always like to start with a patient case. And this is a typical type of patient we see. Our wound clinic is a referral clinic for other wound clinics around us. And we often see the patients that don't do well with standard treatment protocols. Usually they're doing very good care at these centers and the wounds just aren't responding. And this is a typical case. 48-year-old female with prior history of several episodes of DVT, had this large inflamed looking leg ulcer that had been there almost 2 years at the time of her referral to see us. Lots of edema, heterozygous factor V, and her BMI was 42, which is unfortunately common in North Carolina. The initial wound size was about 32 square centimeters. So we initiate our protocol when patients have failed other therapies elsewhere. We just start over. They've usually tried all kinds of therapies, dressings, various modalities, and we just start over and look at the etiology and try to see what's going on with the wound. So we did an excisional debridement of this wound in the operating room, initiated pentoxifylline. We would initiate flavonoids if we had them, but we really don't have good access to them in the US. We perform a biopsy on any old wound like this, as well as a biopsy for culture. We start aggressive multilayer compression. We get venous ultrasound exam on everyone unless contraindicated, and arterial if we're not satisfied with our exam. Now, with this type of treatment protocol, if you look through the literature, there are numerous studies comparing various methods of compression. But it's quite interesting that all of these achieve a pretty similar amount of healing rates of about 2/3 of patients healed somewhere between 3 and 6 months. So compression is effective, but that does mean that about 1/3 of patients are not responding to these treatment protocols unless we're satisfied with 2/3 of patients healed at 6 months, which we are not. And if you look at different risk factors for delayed healing, repeatedly large wound size, long wound duration, and more severe venous disease have been defined as risk factors for delayed healing. So looking at our patient, this is a long duration, large wound. It's not likely to heal in the next 3 to 6 months very often. So our first goal is to confirm the presence of venous disease, because if they don't have any venous insufficiency on exam, you've got to look for other etiologies. And I think this is one thing that is missed very frequently in our field, is treating an ulcer as a venous ulcer that's not a venous ulcer. So we did proceed with our studies, and this patient, you can see, had gross reflux actually through the deep system. Previously, it had both the great and small saphenous ablated elsewhere, and we didn't find any evidence of outflow obstruction either on this reflux study or on a CT venogram. So this patient has pure venous reflux in the deep system, and we're not often going to be able to correct this. We don't think that patients who are morbidly obese and have large wounds like this are great candidates for venous valve surgery. So how are you going to get a wound like this to heal more rapidly than we do with our standard therapies? So that brings us to adjuvant therapies, and there are a large number of different categories of these. One little thing I'm not going to talk about today, but we're really finding a resurgence of interest in good old split thickness skin grafting. You can get these wounds really well prepared and the edema controlled. We think large wounds do well with split thickness. We don't have data yet to support that opinion, but we're hoping to generate it soon. So there are bioengineered dermal equivalents and other substitutes, but today we're just going to talk about mechanical or energy therapies, and just a couple of a wide variety of types of mechanical energy that might be applied. So let's focus purely on negative pressure and then IPC. So negative pressure, pretty simple concept. You put some type of a sponge or dressing that interfaces with the wound, some tubing to draw suction on it, and that connects to some type of a pump. Not rocket science here, but it really was a revelation to the wound field when the first one of these was successfully marketed and brought to bear. And this is because there's just an obvious response that you see in many wounds when you apply negative pressure to them. On the top, you see a pre-debridement diabetic foot ulcer post-great toe amputation. And within 7 to 10 days of applying negative pressure, you get a nicely granulated wound bed that then is appropriate for other therapies to move on to closure. So this has been well validated in the diabetic foot arena, along with this seminal publication from David Armstrong and Larry Lavery in Lancet, where they randomized patients after surgery for diabetic foot problems to negative pressure versus standard care, and they showed significant improvement in healing for the use of negative pressure therapy. But what about venous ulcers? Clearly, the pathophysiology is not the same as a diabetic foot ulcer. And so is the actual mechanism of action of negative pressure therapy going to assist in healing a venous leg ulcer? Well, let's go back and review. Chronic venous ulcers are inflammatory wounds. We know that from multiple different lines of research. Venous dysfunction through obstruction or reflux results in increased ambulatory venous pressure. And this causes upregulation of proteases and pro-inflammatory cytokines and downregulation of the inhibitors of proteases, resulting in this chronic inflammatory state that prevents healing. We know that compression improves this. This is a study published by one of our associates, Stephanie Beidler out of UNC, and she showed that with good compression, the majority of wounds have a reduction in pro-inflammatory cytokines and proteases, but not all of them. So in about 20 to 30% of our patients, they did not have this type of response, and those patients did not heal as well as those that did have a reduction in the inflammatory milieu. Also, there's been several groups that have looked at fibroblast dysfunction, showing that in these chronic wounds, particularly those that have been there for long periods of time, have features of senescence in the fibroblasts. They don't proliferate, they don't secrete typical chemotactic factors, and they really don't induce the neutrophil response that is required for healing. So what is the mechanism of action of a negative pressure device put on a venous ulcer? Well, we have to clearly acknowledge that we don't really know. I'm quite fond of this study out of the International Wound Journal, and I recommend it to you to read because they really go through quite a bit of theory about what NPWT might be doing. But when you see a figure like this, you realize that we really don't have it nailed down. We don't really know. But I do think that there was a nice meta-analysis published recently, and they found 16 papers that really looked more scientifically at the mechanism of action. Now, this was sort of a hodgepodge of human in vivo studies, animal models, and in vitro studies. But what they found were some commonalities, that pro-inflammatory cytokines and protease levels are decreased by the use of negative pressure. It might be that part of it is just removing that wound fluid from the wound itself, is removing a good bit of these materials. But they also showed upregulation of expression of multiple useful growth factors, as well as TGF-beta that we have pretty good knowledge is required for good wound healing. But the downside is that none of these studies actually focus specifically on venous ulcers. But there is one interesting study out there addressing the problem. And this is from Dr. Romanelli's group. And they looked at venous leg ulcer patients, and they took wound biopsies before and after a week of negative pressure, and they compared this to controls. And what they found were significant changes with increases in the amount of angiogenesis, macrophage, and lymphocyte proliferation in the negative pressure treated patients. So this does show us that there is some important and likely useful action of placing a negative pressure device on a venous leg ulcer. So that's nice background information, but we really do need good randomized studies to convince us that it's worth the cost of treating with negative pressure. So the Cochrane Review in 2015 only found one article meeting their standards, and that was this article published in 2006 by Vuurstack and colleagues. And there was a randomized controlled trial, and it was, I believe, approximately 60 patients. And it was a very nicely designed study, at least as well as you could. It's hard to blind patients as to whether or not they have a negative pressure device on. The key thing to know about this study is that the patients were kept hospitalized until the wound was healed. So they had a aggressive excisional debridement, and then they were randomized to negative pressure and standard ulcer care versus standard ulcer care alone. Once the wound was fully granulated, they did pinch skin grafting. And they showed significant reductions in the time to healing, 29 days versus 45 days. By 3 months, 95% were healed in both groups. So we learned several things from this study. Number one, if you're going to keep your patient hospitalized, you should use negative pressure because it's going to shorten their hospitalization time significantly. And if you use this type of approach, you'll heal most patients in 3 months. But I don't know that many of us can hospitalize our patients for that duration of time. And so this may not be relevant to home care as we're doing in most of our centers. There really are no other good prospective studies. Most guidelines don't make a recommendation for or against the use of negative pressure because of the lack of clinical data. And I think right now, based on the cost of home and the need in most homes for home health to assist with the application of these devices, we can't say that we should routinely use them. However, I think if you're going to use negative pressure, these newer, highly portable devices that don't necessarily require home health nursing to apply them would be the way to go. We were involved at our center in the validation of the SNAP portable device and found it non-inferior to standard powered systems. And these can be applied in the clinic and the patients wear them for 3 to 5 days and then they're reapplied. So again, no prospective randomized data, but if you're going to use negative pressure, that would be a nice way to do it. Now, let's talk briefly about IPC, and Dr. O'Donnell, as usual, has done a good bit of my work for me to review much of this information. This way, I'm going to go in reverse direction. I'm going to start about the guidelines first and work my way back. So from the American Venous Forum guidelines that now are beginning to be a bit aged, hint, hint, but guidelines recommended using intermittent pneumatic compression when other forms are not available or cannot be used. But this is a grade 2C, a very low level recommendation. Cochrane Review in 14 found 5 studies that compared IPC plus compression to compression alone. Unfortunately, it was sort of a split show here. 2 of them found an increase in ulcer healing and 3 did not. None of these were really well powered to answer the question, with a total of just over 200 patients being studied so far. So there's really no, as Dr. O'Donnell mentioned, good randomized data to guide us in this way. And I think one of the things about IPC is that we really have to acknowledge that this has not been developed for venous ulcer healing. In applying pneumatic pressure or any kind of pressure, we don't really know what the best parameters are. How much pressure should we apply? Is a lymphedema parameter correct for venous ulcer healing? How much sustain? What's the right frequency? How long should you do the therapy? Is 45 minutes enough, or should it be 3 hours? We have not done any good dosing studies of this method of applying energy to the wound to know whether it would help or not. So you've got lymphedema design pumps out there. They work very well at eliminating lymphedema. And as Dr. O'Donnell showed, combined lymphatic and venous insufficiency is common. So I look to use these when I think the lymphedema component is relevant and important. There are arterial pumps out there. If you had a patient with combined disease, arterial and venous, this may be a useful modality to use if you can get it approved. And then these segmental boots that are used in the hospital, probably not very useful for home ulcer healing at all. And then there are these exercise enthusiasts who like to use pneumatic compression. I don't know what kind of pressure settings they're using, but they look like they're having fun. So we think about traditionally treating lymphedema when we think it's present. So we try to evaluate whether the leg ulcer is purely venous or whether the lymphatic component is a significant part of the problem. And then in those patients, we try to get IPC devices approved as soon as possible. And fundamentally, we know from the study that Dr. O'Donnell presented before that these devices will remove lymphatic fluid from the limb effectively. Using their NIR fluorescence imaging, they showed this quite convincingly in this study. So since the 14 Cochrane Review, there's been no new prospective studies presented. So what do? I think we need lots of options to compress patients with venous leg ulcers. Here's a partial list of some of the modalities out of there. We use all of them. We want all of them in our toolkit. Compression stockings are great for some patients. Short stretch are great for many patients. Multi-layered, really good for patients if they can come to the clinic or have a home health nurse. And in some patients, IPC is going to help. And we think of using these tools like we would an internist treating blood pressure. What dosage does that patient need to get their hypertension treated, and which modality is going to be best for them? We all have many of our patients who fail because of compliance issues, and we sometimes brand them as non-compliant. But is that the way internist thinks when the patient comes back and says they can't take the beta blocker because it's making them so dizzy? No, they find a different medicine to treat their hypertension with. So that's the way we think of doing this, is using each of these different modalities to achieve the effect that we want of control of edema. And for some patients, we think the less active, those that have more stasis versus venous reflux, IPC is very good. If they just can't manage any of the other options, they can generally get on an IPC sleeve and plug it into a pump. And those that have upper leg edema or venous obstruction sometimes do well with these pumps also. So in conclusion, I think we need lots of tools in the bag to have a high rate of success with BLU. Negative pressure and IPC are both mechanical therapies, and they're helpful at stimulating changes in wounds and the lower extremity. Both are expensive relative to other therapies, so they're probably not going to be first-line therapies, particularly since they're not adequately studied in clinical trials yet. But I think both are likely to be useful in specific subset of patients with recalcitrant ulcers. Thank you again, Sergio, and your group for putting together this outstanding forum for exchange of ideas, and I look forward to questions.
Thank you so much, Bill. The only sad part is that you cannot listen to all the clapping of the more 1,000 people that we have over here. So as always, we move now to the scientific word round, Bill, and we start again from Europe. It's my deep honor to start with the Professor Elena Guranova. She's the president of the Bulgarian Society of Phlebology and also of the Balkan Venous Forum. So Elena, the mic is to you for your question to Bill.
Hi, thank you, Bill, for your excellent presentation. Thanks, Sergio, for giving me the chance to have a question. Venous leg ulcers change dramatically all patient quality of life, making most of them practically disabled. The successful treatment of venous leg ulcers requires an effective multidisciplinary approach: surgical intervention, drugs, wound dressing, and effective compression therapy. According to my experience, the key starting point is to cut off the reflux when it is present. Moreover, the same conclusion was claimed by Professor Alan Davis in the large EVRA study published last year. The ulcer's treatment effect strongly depends also on the precise definition of the wound development stage. In this perspective, my question to the honorable speaker is regarding the intermittent compression therapy. If applying a multi-chamber device, do you prescribe a lower level of compression for the ulcer area compared to the pressure set to the rest of the leg?
Yes, I think that's a great question. And the honest answer is we don't have the information looking at different pressure settings to know what will work better. So I start with the same settings we would use for a lymphedema patient, unless the patient has pain with that. And then we try to dial the pressure down to what they can tolerate. Most of the time they don't have pain, so we just proceed with the standard pressures for lymphedema. But I would completely acknowledge that we may do better if we increase the pressures. I'm not sure if Dr. O'Donnell has any thoughts on that, or if he's tried that, because I just don't think we know the answer.
Thank you so much, Bill. We will move forward, and then there will be a discussion, and eventually Tom will jump in. So we fly all the way to Latin America now, and we have Oscar welcoming the Continental Top Expert Representative.
Thank you. Let me introduce a true friend, a real brother to me, Dr. Alfredo Prego, President to the Uruguayan Society of Phlebology and Lymphology, who dedicated to treat venous ulcer for more than 10 years.
Alfredo?
Oh, thank you, Sergio and Oscar, a real friend. And as you said me, I do aim to use my only shot, but with a double-barreled shotgun. It's a little trick. Dear Professor Martin, this is a great presentation in a very controversial issue. And my question is after the initial treatment, if the venous leg ulcer fail in decrease inside at least 30% over the first 4 weeks, we know that it has a 70% chance to not heal at 24 weeks. This is an old paper for the British Journal of Dermatology, Dr. Margolis. In this particular situation, do you consider adjuvant therapies like negative pressure wound therapy in your therapeutic approach, or do you recommend it from the beginning of treatment? And in the mixed ulcer, venous and arterial component, do you think that the vacuum can be harmful or not? Thank you so much.
Thank you very much. Great questions. I appreciate you highlighting that 3 to 4 week time period after you start your treatment protocol. One of the biggest failures we see in our wound clinics is continuing the same thing for month after month without improvement. It's not going to change if it doesn't, make progress in a period of time like that. So the first thing we do is we reevaluate. Have we missed something in the etiology? And so we typically, if we didn't biopsy the wound before, we biopsy it to look for other factors. We culture those wounds and often find a resistant bacteria involved. And we also make sure the arterial supply is good. But we typically, that is the time frame we think of adjuvant therapies, is if we're not seeing good improvement in 3 to 4 weeks and we're sure that we have the etiology correct. The other thing I think that's failed often in that time frame is good compression. So if we haven't eliminated the edema from the leg appropriately, that's the next job, and we switch to a different modality. But that also, again, if we're hitting the right things, but the wound isn't healing very well, then we think of adjuvant therapies. Your other question about arterial and venous ulcers, we definitely don't seem to have much trouble with them with negative pressure, so I generally proceed unless they have severe arterial, such as critical limb ischemia, and we're going to revascularize the patient before doing anything else.
Thank you so much. And now we fly not back to Europe because the next representative is actually representing on the continent. So Willie, can you introduce the next?
Yeah, next we have Professor Marco Romanelli from the University of Pisa, who is the current president of the World Union of Wound Healing Societies.
Marco?
Thank you, Sergio. Thank you for inviting me. And thank you for the opportunity to ask Dr. Marston about negative pressure in venous leg ulcer. The slides were very precise, and we always, as a dermatologist, we wonder, looking at the technology and the increasing amount of sophistication of those devices, in your opinion, is the technology in the future will drive more option for venous leg ulcer according to negative pressure treatment? And also, do you think, do you prefer to have a device, a portable device for negative pressure, which is going to collect the exudate outside of the wound bed or stay on the wound bed? Thank you.
Excellent questions. We were lucky enough to be a clinical research site for the development of the SNAP device. And some of the patients in that study where we compared it to powered negative pressure were venous ulcer patients. We found that if there's too much exudate, that's not so good for those devices. You really need a powered device with a larger capacity to manage exudate. But in the less exudative wounds, the portable devices are very useful. Patients much prefer them, and it allows them to do one of the other things we all know is beneficial, which is to exercise. So for a certain slice of the pie of venous ulcer patients, I think the portable devices are the way to go. We clearly need more research to further define the mechanism of action and exactly which patients benefit, because we're having problems with reimbursement with the devices universally in this country, and we need more information.
Thank you so much, Bill. Now we fly on the way to Asia for somebody who needs no introduction. Roy Varghese, we have always enjoyed his comments during meetings about ulcer treatment. So Roy, the mic is
Thank you. Thank you, Dr. Sergio. And it was been an excellent presentation, though the net was a little troublesome here. Very, very contentious topic. What I want to say is nicely brought out the question of infection, exudates, and hypoperfusion in the tissues. My question is, having said all these three important components, including lymphedema, which compression device or a negative suction device, how will you choose for each patient? How will you select the patients? What type of compression therapy that we should undergo, give the patient, or which type of patients need a suction therapy? Thank you so much.
Thank you. Well, I think in terms of IPC, we generally, because they're higher cost options, they're harder to get approved by insurance, and many insurers require 6 months of standard compression and failure before they're approved an IPC device. So that's generally how we go. If we're not getting where we need to be with multi-layer compression or any of the other modalities, then we will try to get them approved for an IPC device. As far as negative pressure, I will acknowledge I have not used that extensively in venous leg ulcers. We've usually considered that as an excellent granulation tool for diabetic foot wounds and pressure ulcers, but we haven't gone to that often in venous ulcers until the highly portable devices came around, because you don't want your ulcer patient tethered to a power source all the time. And these highly portable ones do allow them to be mobile. So we are starting to use them more with the emergence of these devices.
Thank you so much. And now we move forward for the open discussion. And of course, this is the time to welcome Tom O'Donnell to give the comment he was waiting for giving us before. Tom.
Thank you very much, Sergio. I would just comment on what type of pressure do you use in a patient with an open venous ulcer? When you look at the physiology, you only have two alternatives, since the Levick studies show that you can't force the fluid back from the interstitial space into the arterial venous vascular system. Your two options are lymphatics or going up through the interstitial space. The two types of, I would say, advanced pneumatic compression devices are the high pressure squeeze and hold and the multiple finger-like pressure that simulates manual lymphatic drainage, lower pressure. From our studies, and they've actually compared the high pressure versus the frequent low pressure type of device, there doesn't seem to be a difference. Both recruit lymphatic vessels and both mobilize fluid along the interstitial space. So I just think that what will dictate it certainly will be, if the patient has a mixed ulcer, you want to avoid a device that requires a high pressure. Being careful not to specify the trade name in going more with a generic definition, as Bill can appreciate.
Thank you, Tom. Bill, any comment on this?
And I agree with Tom, always.
That is great. So now we move to the open discussion, and we have the best question in terms of numbers of likes coming from friends we all know. Professor Kabnik is asking, you mentioned that obese patients are not candidates for deep venous valve therapy. Is that also true for deep venous obstruction? What about recommending these patients to a bariatric therapy as part of your treatment bill? And also, Tom, maybe we can open this question to both.
I guess I would first say that there are no absolutes in considering patients with obesity. And so I wouldn't absolutely say they're not candidates for venous valve, but and I think they're good candidates, most of them, for deep venous stenting. Again, there are patients that are, super morbidly obese that maybe, the best thing for them is bariatrics, but we run into a big problem that our bariatric surgeons don't want to do that surgery on a patient with an open ulcer. So you've got to get that wound healed or nearly healed before they'll do anything for that patient. So we will stent them and do other things and try to do everything we can to get the wound healed.
Tom, would you like to make a comment on this?
Just a brief comment. Thank you all for your question. The point is that bariatric surgery can reduce the abnormally high venous pressures that are associated, related to the intra-abdominal pressure. So I think that should be a strategy, and I appreciate what Bill said. I think the reason that valve transplant is not a viable option is that you will blow out the valve unless you've corrected the intra-abdominal pressure component of the deep venous pressure cycle.
Thank you, Tom. We have other 2 minutes, so I would take this question for the both of you, Bill and Tom, from Vladimir Krishanovic. Is asking us if you recommend venous active drugs for venous ulcer treatment, and if yes, what kind of venous active drugs? And I think a comment could be also that we recently mentioned also in a document that in reality, FDA is not using many of the venous active drugs we are using, for example, in Europe. So this could be, for example, a bias in the answer, I think. But Bill, and then—
You're exactly right. We have no FDA-approved phlebotomics here. So we recommend herbal therapies like horse chestnut seed. There's no evidence whether it heals wounds or not, but there is evidence that it reduces pain related to varicose veins. So I'm aware there's much in Europe. You might want to answer that question, actually.
Yeah, we actually recently published with many of the friends who are here with us, the document after the last winter meeting where we were looking at the guidelines, and both AVF actually was mentioning, for example, sulodexide at the time, and also MPFF as potential products. Tom.
Nothing to add. Don't have the experience, just the serendipitous experience reading the literature. I'm like Bill.
Okay, so we are perfectly on time to move forward now with the honorary chairs. So I will share the screen again to welcome our honorary chairs, and we start from Giovanni Mosti. Needs no introduction, of course. He's the president of the International Compression Club, so perfect person to give us his take-home messages after these brilliant lectures. Giovanni? Giovanni, are you with us? We cannot hear you. Yes. Okay.
Sergio, first of all, thank you so much for your kind invitation, and I want to congratulate with you for your brilliant initiative. This Vein for Food and Food for Veins allows us to stay together all the weekends, and this is a very excellent opportunity to increase our knowledge in phlebology. I want to obviously congratulate with the speakers. You choose two excellent speakers, and from these excellent speakers, we couldn't expect nothing less. Brilliant presentation by the two of them. I just want to underline that you told me to give some messages, take-home messages, and I want to stay a little bit on the presentation of Professor O'Donnell. That gave us a very important news also for treatment, because certainly you know that a lot of surgeons are convinced that after venous procedure you don't need anything else to heal the ulcers. And there are also some provisions that after surgical treatment, the compression treatment will decrease and decrease and decrease over years. And this is certainly not true in ulcer treatment if the hypothesis of Thomas O'Donnell is true, and I strongly believe that it is true. So at least in venous ulcers, we need to keep on compression even after the eventual surgical procedure. An important point I would like to discuss, but it is impossible now, is the comparison of sustained compression with intermittent compression, because Professor O'Donnell certainly knows that sustained compression is very effective also in lymphedema treatment. And so it would be very nice to compare intermittent pneumatic compression and sustained compression in this specific infection prevention, because he stressed so much this concept of intermittent pneumatic compression to prevent infection. And it would be very nice to know if the routine treatment of venous ulcer, that is sustained compression, is effective or more effective or less effective than intermittent pneumatic compression. I also want to congratulate with Bill Marston, because he definitely clarified that we can survive, at least in ulcer treatment, without negative pressure and intermittent pneumatic compression. And this is a very important message. We should limit this indication to, as he said, very well in his conclusion, to the subset of venous ulcer patients who don't heal with standard treatment. So at the end, my take-home message, I will again start from the beginning. It is very important, at least, to have a correct diagnosis of ulcers, because unfortunately, still in 2020, we have a lot of patients underdiagnosed, badly diagnosed, or not diagnosed at all. And this is the starting point. And the second point I want to stress, and you know certainly why, I'm a compression addict, the importance of a good compression therapy. Compression, by the way, also in the American document, is the only therapeutical procedure who got the level of evidence 1A, and they examined, if I'm not wrong, 73 or 75 procedures. So the only one to get level 1A is compression. And at this propos, I would like also to stress that we need not only compression therapy, but a good compression therapy. That means effective in terms of exerted pressure and tolerable by the patient. Thank you so much again for your invitation, and my best regards to all the speaker and the audience.
Thank you so much, Giovanni. Now we move forward for the next honorary chair, would have been Joe Raffetto. I like this quote: there is only one kind of shock worse than the totally unexpected, the expected for which one has refused to prepare. Because Joe unfortunately had a sudden commitment for which he couldn't join us, but he has been so nice to be with us with the video. So we will play his video and his comments.
Well, welcome. I will be your discussant for Professor O'Donnell and Professor Marston. Their wonderful lectures that they provided, and I congratulate them, as well as Professor Sergio Genesini for a wonderful virtual meeting, the VWIN Food for Veins. So I have nothing to disclose, no conflicts of interest, and I will be providing you some of the summary and highlights and pearls, if you will, of these two wonderful lectures. The first one is from Professor O'Donnell, the role of lymphatics and lymphedema in advanced chronic venous disease. And as he mentioned, 45% of edema is attributed to phlebital lymphedema. Other causes are, of course, cancer-related, as well as inflammation and infections. The interstitial fluid reabsorption is mainly via lymphatics, not the postcapillary venules. This is a modification and understanding of the Starling laws, which have now been modified with the understanding from both human and animal studies that there's a glycocalyx in the venules that inhibits fluid reabsorption, and that the importance of the interstitial hydrostatic pressure as well as the oncotic pressure are critical components. And therefore, this fluid that's collected in the interstitium has to be reabsorbed via the lymphatic system, nearly 100% of it. There's a significant decrease in the lymphatic function in patients with advanced chronic venous disease, the C4 through C6, and especially in venous leg ulcer patients. One can see from his paper that was presented the dermal backflow, especially in the calf and near the ulcer bed, as well as the impaired propulsion and decreased lymphatic flow. There are a number of studies that have been utilized, including lymphangiography, lymph scintigraphy, and now near-infrared fluorescent with indocyanine green, which he demonstrated some wonderful images, both where you can obtain anatomy as well as the pathophysiology, and also quantify the dermal and lymphatic reflux. One always has to evaluate the outflow obstruction and the superficial and perforated reflux. This is standard in our clinical practice with patients with advanced chronic venous disorders. However, it is important not to underestimate the treatment of lymphedema, which is an extremely important component of patients' overall care that have advanced chronic venous disorders. He demonstrated that advanced pneumatic compression devices versus conservative treatment demonstrated to decrease hospital admissions and decrease the utilization of the physical therapist, as well as an important factor is decrease the infections in these individuals. All of this equates with increased healthcare cost savings, which is of critical importance in our health economics. More studies are obviously required to understand both the function and treatment of the lymphatics. I'd like to now move on to Professor William Marston's lecture on negative pressure wound treatment, as well as the intermittent pneumatic compression. Do we really need them? Well, we know that venous leg ulcer pathophysiology is quite complex. I actually have provided an online lecture previously for your viewing. We have to adhere to proper venous leg ulcer principles, which obviously means a good history and physical exam, evaluation of pulses. We have to remember that about 20% of these individuals can have concomitant arterial disease in the presence of venous insufficiency and venous leg ulcers. Good wound care with debridement, and as well as biopsies for those patients who have had a venous leg ulcer for greater than 4 to 6 weeks is important. And of course, appropriate compression is critical. He demonstrated that large venous leg ulcers that are greater than 20 centimeters squared have decreased healing at 10 weeks versus smaller ones. This is a well-known fact. And we would consider some of these ulcers as refractory. And this is where we need other modalities. Certainly we can use advanced biologics, such as the skin equivalents or the placental derivatives, as well as the extracellular matrices. There's also energy with ultrasound and electromagnetic. And what this talk discussed was mechanical, the negative pressure wound treatments, and the intermittent pneumatic compression. The mechanism of negative pressure wound treatment appears to involve multiple pathways with perfusion, growth factors, angiogenesis, and cell proliferation. If one wants to sum it up, it appears to really decrease inflammation and increase growth factors. Unfortunately, we don't have great studies. We have one randomized controlled trial, which met all the inclusion criteria, and with negative pressure wound treatment, which appeared to help patients with venous leg ulcers in healing. However, this was limited by a small study, and we really don't have good guidelines and evidence to give us proper guidance in using this for all patients. And we have to remember this is also costly. The intermittent pneumatic compression, well, there's poor evidence, there's unclear dosing and duration and the intervals, as well as the pressure, and also this becomes costly. It doesn't mean we can't use the devices, but we have to be selective. What's important is that we adhere to principles of venous leg ulcers, the wound care, and also remembering good compression. I thank you for listening and enjoy the rest of this meeting. Bye-bye.
I deeply thank once again Professor Raffetto, and now it's my deep honor to introduce Professor Paolo Zamboni, one of my mentors from the University of Ferrara, who will give us his take-home messages. Paolo, are you with us? Yes. Unmute yourself, or Khaled unmute him. Khaled, if you can unmute him. Okay.
Thank you for inviting me in this beautiful webinar. I really enjoyed the speakers and then congratulate both speakers. And also I was very interested because today the focus was on 2 out-of-law treatments because are not recommended by the current guidelines. So lymphatic system and treating the lymphatics in venous leg ulcer is not recommended. And to me, it's very important. And it's very important to improve our knowledge in this field. And when we have cases with ulcer installed or recalcitrant or no progression along months, we certainly need to understand more of the lymphatic system and also to find new strategy for improving the drainage and the mutual venous and lymphatic function to drain the legs. As far as the Bill Marston presentation, I appreciated very much the balance of his speech, but I think that even the negative pressure does not have any evidence in venous leg ulcer, could be considered in cases in the clinical setting where we face with people with multiple antibiotics resistance, recurrent infections, and maybe this could be an option to take into consideration. And also we need more investigation in a subset of patients that really represents a challenge in the field. Finally, there is also another out-of-law treatment that is cellular treatment are not considered in the SVS and UAP guidelines, but self-treatment, for example. Really, in the last year, there is an increased number of papers about this kind of treatment. You may have harvesting from the adipose tissue, also for peripheral mononuclear cell. This treatment get more likes, and this have to be taken into consideration because we have also randomized trial, and we have evidence of efficacy and safety, and also we know new biomarkers that may predict healing time, may predict to control pain in these patients, and so also are new weapons to take into consideration because also lymphatics and the capillary beds are increased by the cell treatment. This is very important. Take into consideration what the speakers today told us. So cell treatment are gaining evidences, and adipose derived stem cells and peripheral mononuclear cells are promising technique. And I suggest to work also in this direction because really are consistent with both the speakers of the today meeting. So thank you for your attention. Okay. And this is my comments.
Thank you so much, Professor Zamboni. Now we go toward the end, but this time we will make an exception. We'll take extra 5 minutes because indeed another quote that I like is difficulties are opportunities. And since we missed one of the honorary chairs in person, and we have the pleasure of having with us the president of the World Union of Wound Healing Societies, we will leave the mic also to Professor Romanelli for a comment from his side. Marco?
Thank you, Sergio. There was a really brilliant Sunday afternoon. Once again, excellent speakers, excellent questions and answers from my evaluation. As a president of World Union Wound Healing Society, I like to share this opportunity, food for veins and veins for food, like a mutual exchange of opportunity together with our society, which we think is an umbrella society grouping worldwide all the scientific involved societies in wound management, like International Compression Club is having an annual supporting society meeting every time. As you know, the conference, because of a virus problem, was postponed up to 2022, which will be once again in March in Abu Dhabi. But we will continue during the time frame between now and Abu Dhabi to work with everyone, and particularly with opportunities in phlebology. So feel free to visit our website and share with me any opportunity which we can improve together on behalf of our patients. Thank you once again, Sergio, and thank all the panelists, and looking forward for next webinar during July and August. Thank you.
Thank you so much, Professor Romanelli, a true honor. I've received many thanks, but it is me thanking deeply Professor Bottini and Professor Cei, because without the teamwork, nothing would have been possible. So I will leave for the final remarks the mic to Professor Bottini and then to Professor Cei. Oscar?
No, nothing more to say, Sergio. Only show us to remark the importance of education for the medical community in benefit of the population. And I congratulate all the colleagues for their insights today. See you next Sunday. Thank you.
Gracias, Oscar. Willie?
Yeah, from great great speakers from our speeches from Dr. O'Donnell and Dr. Marston. We understand the etiology and modality of treatment, but again, more evidence and science is needed on these modality. And with that, good morning, good afternoon, and good evening.
Thank you so much, Willie, for all you do, and also Oscar. We invite you now to next Sunday dedicated to Deep Venus with other two wonderful keynote speakers and a truly stellar faculty. I take this chance to once again deeply thank all the people involved in this global effort in humanitarianism and also in educational advancement. I deeply thank these two stellar keynote speakers of today. Really, the level was top notch. And I also thank them for the time they will use for answering to all the questions we have received in the question and answer box. We have to look at the numbers, but for sure we are more than 1,000, so I'm sure I have to deeply thank once again all the stellar faculty and all the involved people. And with this, I ask for your forgiveness for these 5 extra minutes of delay, but we had Professor Romanelli, and it was a pleasure to welcome him and all of you with us today. So once again, deeply thank to all of you, and see you next Sunday. Ciao.
Bye-bye.
Bye-bye.
Bye.
Bye, Marcelo.